بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد المرسلين. اللهم ادخلني مدخل صدق واخرجني مخرج صدق واجعل لي من لدنك سلطانا نصيرا. طبعا اليوم هو اليوم الأخير في الكريتيكال كير اسينشال كورس اللي كان بين الدوحة عند غزة which started on Sunday and was with collaboration between AUG Medical College and the Qatar Critical Care Society. طبعا today we have two lectures, the non-invasive ventilation and the liberation from mechanical ventilation. The first lecture will be for Dr. Hani Al-Jaouni. He's a senior consultant in pulmonology critical care in HMC. He's holding pulmonology critical care board from the States. He's one of the experts in his field. Dr. Hani would like for this lecture to be interactive. So for the audience, whenever you feel you have a question, you want to answer a question, just unmute yourself and go ahead. Dr. Hani, can you start, please?
Inshallah. Assalamu alaikum.
Wa alaikum assalam.
Bismillah ar-Rahman ar-Rahim. Inshallah, today we'll talk about non-invasive mechanical ventilation. The objectives will be to review the indications of non-invasive ventilation or NIV, understand the contraindications, discuss how to initiate NIV and how to monitor the patient after that. And there are some uncertain indications. We'll touch base on these and also talk about some potential harm that might happen from NIV and troubleshooting if it happens. We'll start with this case. 62-year-old man presented to the emergency room with 1 day's history of shortness of breath. It started quickly with some cough and wheezing. He was not sure if he had a fever or not, but he had no sore throat. His sputum is frothy, pinkish in color, with no real chest pain, but he feels tight and heavy. And on examination, he was in distress, unable to finish one sentence at a time, using accessory muscles for breathing, blood pressure elevated, heart rate is 105, irregular, respirations 35, his temperature on the lower side. Pulse oximetry showed a saturation of 88% on room air. However, it increased to 92% with 5 liters per minute by nasal cannula. His jugular vein is distended. His lungs with auscultation had bilateral crepitations up to the mid-lung zones and occasional wheezing. Heart is irregular, lower limbs with trace edema. His blood gases showed pH of 7.34, PCO2 34, PO2 58, and bicarb of 20. So I think the case is obvious. Anyone would like to say anything? Anyway, the patient is obviously having acute pulmonary edema, most likely from heart failure. And how would you treat or help this patient? You want to improve his oxygenation and his breathing. One possibility is to continue with the same pulse oximeter, with the same oxygen delivery with 5 liters by nasal cannula. His CO2, his pulse oximetry has improved, and we can continue the same, or use a face mask with 6 liters per minute of oxygen, or non-rebreather mask with 10 liters of oxygen, or use an IV with CPAP of 5 centimeters and 3 liters of oxygen, or intubate and place on volume assist control. So if you want, anyone would like to share his answer, but probably I would choose 4, maybe 5, and we'll discuss why 4 would be an appropriate treatment. So in general, when we talk about mechanical ventilation, what is the indication? So in general, you want to help the patient if he has decreased level of consciousness, or to treat type 1 hypoxic respiratory failure, or type 2 hypercarbic respiratory failure, or mixed respiratory failure, or if the patient is just having increased work of breathing, like patients with severe sepsis and septic shock. So these are the major indications of mechanical ventilation. Now, what is an NIV, or non-invasive ventilation? It's the administration of positive pressure ventilation without the artificial airway. So you don't have to put any airway inside the patient. And it includes the CPAP, or continuous positive airway pressure ventilation or therapy, and non-invasive positive pressure ventilation. CPAP is usually applied by an adjustable flow meter, like the small machines. Sometimes people, they can use them for obstructive sleep apnea, and positive end expiratory pressure, or PEEP valve. The valve will keep a pressure at the positive pressure inside the lungs and the airways at the end of expiration. The non-invasive positive pressure ventilation requires a ventilator because it is more complex. Indications of NIV. There are two major indications that have been tested repeatedly and show that there is real benefit from using NIV for these two conditions, which are chronic obstructive pulmonary disease, or COPD, exacerbation, specifically those that are complicated by hypercarbic respiratory failure or increased CO2 retention. The other condition is cardiogenic pulmonary edema, like the case that we just discussed. So these two indications are, you are never wrong if you want to use NIV for such patients, taking into account that the patient is appropriate for this treatment. Other indications that are somewhat controversial or still under investigation include hypoxic respiratory failure from pneumonia, or someone who is immune compromised, ARDS, and asthma. NIV has been tested for all of these. However, the evidence is not very strong to justify using NIV for these conditions. However, if you feel that the patient can be cooperative, and you think that you have enough monitoring, you probably can try NIV for these patients, but have a very high or actually very low threshold for intubation if the patient did not improve or deteriorated. Other indications, like after extubation, if you think that the patient might go into failure after extubation, you can apply NIV to avoid reintubation. Also post-operative respiratory failure. Some patients after surgeries, especially major surgeries, they might be still under the effect of the sedation, or they might be weak, and NIV might be helpful for them. Pre-intubation oxygenation, if you have someone in the emergency room, you want to intubate. In preparation, as you get things ready, you can apply NIV for them to improve their oxygenation. And if the patient is refusing to be intubated, but you still want to help them with NIV, or sometimes patients who are end-stage disease, whether it's cancer or some other, like COPD or heart failure, and for palliation of shortness of breath, you can use NIV. So in acute cardiac pulmonary edema, the NIV would reduce the pulmonary workload, improves cardiac output, enhances lung compliance by forcing the fluid out of the alveoli, by improving the pulmonary vascular resistance and gas exchange. Also, the positive pressure ventilation prevents alveolar collapse, enhances alveolar expansion with inspiration, and improves airway compliance. All of these will lead to improved oxygenation in cardiac pulmonary edema. The left ventricular function usually would improve with positive pressure ventilation or non-invasive ventilation by reducing the preload and the afterload, reducing the myocardial oxygen demand, and enhances hydrostatic displacement of alveolar edema, meaning that it improves the emptying of the alveoli from the fluids. However, right ventricular failure might be a different subject, and it might react differently to positive pressure ventilation. However, the net benefit in heart failure with non-invasive positive pressure ventilation depends on relative left and right ventricular functions and afterload. This illustration shows the effect of the positive end expiratory pressure on the function of the right and left ventricles and the balance between both of them. You can look at this later on. We'll talk about another case. Any questions so far? I mean, I might be going too fast, but any question?
No.
All right.
Clear, sir, clear.
So another case, 70-year-old guy who has 4 days history of cough and difficulty breathing, started with sore throat and fever, has history of chronic bronchitis and long-standing smoking, sputum large in amount with thick and yellow, and on examination, he's also in distress using accessory muscles, unable to finish one sentence at a time. Heart rate is 95, blood pressure on the lower side, respirations 30 times per minute, pulse oximetry 90% on 5 liters per minute by nasal cannula. He has diminished breath sounds bilaterally with some crepitations, but mostly diffuse wheezes. And blood gases showed pH of 7.3, PCO2 60, PO2 of 65, bicarb of 28. So this is again, a case of COPD exacerbation. Yes, probably acute on chronic CO2 retention, but there is obviously some CO2 retention, and you want to help this patient. So again, how would you treat this patient? What are your goals of treatment here? You want to help his oxygenation. You want to help with his CO2 retention and improve ventilation to decrease his CO2 level, and also decrease the work of breathing. Because if you don't help him with his work of breathing, eventually he will probably fatigue and become in worse respiratory failure and will need intubation. So the sooner that you start the NIV, the better for this patient. However, how would you know if NIV is good for a patient or not? There are some factors that you need to look at. First, the patient factors. Is the patient is awake and cooperative? So you need to have a patient who understands what, at least, how this treatment is working, and be cooperative, not to remove the mask frequently, and if he is in need of help, that he is able to call for help. You need someone who doesn't have severe illness, regardless of the type of illness. Any kind of severe illness, like for example septic shock or similar cases, probably are not appropriate for NIV, because these patients are more prone to decompensate very quickly. Younger age probably would benefit better. This is by the observation of the studies. Less air leaking and intact dentition, meaning that if you apply the mask on the face of the patient, he doesn't have anything that will make it more likely for the air to leak. For example, someone with very thick beard, عنده لحية يعني كثيفة, or loss of teeth. When you have loss of teeth, the seal of the mask on the face will be less effective. Moderate hypercarbia, meaning that the CO2 is not very high. It is increased, but if it is less than 92, there is more chance that the patient will respond to the treatment. But if it is higher than that, unlikely that the response will be enough. Also, moderate acidemia. If the pH is less than 7.1, probably the patient is not appropriate for NIV, and you would probably go directly to intubation. In general, if you feel that the patient will have improvement with this treatment within 1 to 2 hours, then it would be worth trying NIV first. However, like any other patient, like any patient you start with NIV, you need to monitor very closely, especially at the beginning. Now, other
Also
factors.
secretions, right, doctor?
I'm sorry.
Also, if they have a lot of secretions.
Correct. Yeah, because if they have lots of secretions, they need to clear their airways very frequently. They might need to remove the mask very frequently. But however, if this is the only problem and he is still cooperative, I probably will still use it. I'll give it a try. But you're right. I mean, if you need to remove the mask frequently, most likely he will lose the benefit. Hospital factors, again, we were just talking about the condition in Gaza just before we started the meeting, and Allah ya'inkum, lakin, if you have the equipment, use it. If you know how to use it, give it a try. It is worth trying, because if you can avoid intubation for a patient, this is a big plus, big achievement. So if you have available the equipment, the ventilator, the circuit, and the mask, and you are willing to try it, and the patient is cooperative, then give it a try. Again, the equipment, you need the ventilator, you need the appropriate circuit. If you have someone with no CO2 retention, for example, those with heart failure and pulmonary edema, maybe you can use a one limb circuit, meaning that the inhalation and exhalation are in one tube. However, if someone is having CO2 retention, probably it's better to use the two limbs, where the inhalation is in one tube and the exhalation in the other, so that they will not rebreathe the CO2. And if you have a ventilator where you can monitor the tidal volume and how much FiO2 you're giving to the patient, and these ventilators are better to detect if there is significant air leak. Because if you apply the NIV and there is significant air leak, probably you will not benefit from this treatment, even if the patient is cooperative. However, if the leak is too much, the patient is not getting enough pressure or volume to help him with his condition. So in general, if you use an IV, you will have probably lower mortality, reduced rate of using invasive mechanical ventilation, which is more costly, also decrease the incidence of nosocomial infections because you avoid intubation. And in general, when you use non-invasive ventilation, the treatment period is less than invasive ventilation. So in that case, you will have less infections. Also, you will lose less sedatives, because if anyone who's intubated, you will need to sedate them, maybe even paralyze them, and also decrease the ICU and hospital stay. And all of these are supported by literature. Contraindications for NIV. Any ideas? Anyone wants to talk? Share. So just, for the sake of time, if the patient is in arrest, like if they're having cardiac arrest, or they have already stopped breathing, or their breathing is very ineffective, they can barely move any air, these patients are not suitable for NIV. If the patient is having a shock state, any kind of shock, they are not suitable for NIV. If they have a severe illness, for example, a thyroid storm, or severe increase in the hyperdynamic state, these patients also are not fit. If you think that the patient's illness will need long time of mechanical support or mechanical ventilation support, then maybe NIV is not good for them. Maybe you better go with invasive ventilation from the start. If the patient is not cooperative, if they are claustrophobic, meaning that they are afraid of having something on their face, they cannot tolerate it, they cannot protect their airways, someone who has neurological disease and they are unable to protect their airway or unable to clear their secretions by themselves, then don't go for an IV. If the level of consciousness is very low, it is not appropriate. High aspiration risk, again, if the patient is having had recent surgery to their face or trauma or deformity, for example, micrognathia, or if they have very small lower jaw. In this case, the mask will not fit. So, I mean, it will not be useful if you use it. If they have upper airway obstruction, for example, a big tumor, or recent esophageal anastomosis. In this case, they say that by theory, there might be dehiscence of the sutures, meaning the wound will open up. And if there's active upper GI bleeding. So in these cases, it's not advisable to use an IV. You probably want to protect the airways in a better way and intubate the patient right away.
Please, Doctor, لو سمحت. The patient who has an NG tube, nasogastric tube, can be done CPAP mask in his face or not?
Yes, you can. Some of the masks, they have some kind of a groove where you can, fit the NG tube within it. But even if you don't, you can still use it because the leak would not be too high to overcome the benefit of the NIV. And in many ventilators, they can compensate for this small leak. So it would be fine to use it. Inshallah. So using your ventilator, first look at the circuit. Again, if you have someone with CO2 retention, you might want to use a double limb circuit. Also, any kind of circuit you use, you want to apply heat and humidification. That will make it easier for the patient when they have this treatment. I don't know what kind of ventilators you have in Gaza. Like in most of the, if not all of the ventilators, they can be used as an IV. If you have the small, like CPAP or BiPAP that is portable, that people can take them to their home, maybe you can use it initially, but the treatment is not maybe as effective. You cannot tell how much tidal volume they are getting, how much air leak is happening. You cannot really adjust the FiO2. So in general, if you can use a ventilator would be better. Interfaces, what kind of mask you should use. There are many masks that are available. The oronasal mask or orofacial or face mask, it covers the nose and the mouth. This is most commonly used mask and reasonably well tolerated. Some people don't like it because of claustrophobia. It eliminates the CO2 effectively, and it has been the one that has been tested most of the time, in most studies. The nasal mask covers only the nose, and it is an alternative if the oronasal mask is not tolerated. However, many patients, they would have air leak from the mouth, especially in the acute phase when the patient comes in with acute respiratory failure. They are mouth breathers. So it might not be appropriate. However, if you have a chin strap that comes underneath the chin and over the head, it will keep the mouth closed. And in this case, it will minimize the air leak. So you can still use it if you can have a chin strap to keep the mouth closed. Nasal prongs, the same principle. They are also nasal pillows. They are inserted inside the nasal openings. It is more tolerated by the patients, but maybe not as effective as the oronasal mask. Full face mask, and it includes the eyes in addition to the nose and mouth, not very well tolerated. However, might be an alternative if you start to have some skin abrasion or skin necrosis over the nasal bridge, especially if you have been using the NIV for a while. The helmet, which covers the whole head and surrounds the whole head, it allows the patient to talk, read, and drink through a straw that you can introduce inside. Minimize the complications of skin necrosis, gastric distension, and eye irritation. However, the way it works as a reservoir for oxygen. However, the disadvantages is that CO2 can accumulate inside. There's high nose level. There are some reports of deafness because of the high noise level. And there's more asynchrony, not well tolerated by the patients.
I have a question.
Yeah.
How are they going to talk on the phone?
Well,
I'm so sorry.
That's
I'm going to mute
can have a screen inside. You know, the next generation probably would have a screen.
Thank you. Sorry.
No problem. So initiation, first, before you initiate any NIV, you need to know that you have the ability to monitor the patient. Your priority is the safety of the patient. So if you can monitor their pulse oximetry, their heart rate, their blood pressure, that would be excellent. And that's why most of the time it is initiated in the emergency room or the ICU, or if you have a high dependency unit where you have monitors. However, if you have portable monitors, you probably can start it in the medical ward. So have the patient in the bed or even in the chair at 30 degrees angle is fine. Select your interface, select the mask that you want to use and make sure that it will fit the patient. There are ways of testing if the mask will fit or not. And usually these are available with the ventilators. I don't know if you have respiratory therapists, but usually they know about it. The ventilator settings, depending on what you want to do, is it just pulmonary edema or you want to do more ventilation for the patient? You connect the mask with a tube and turn on the ventilator and then apply the mask and the headgear and strap the mask in place. However, don't strap it too tight because that will lead to more complications of the skin if you keep it for a long period of time. One practical advice, and I find it very useful if you really explain to the patient what's going to happen, tell them that it might be uncomfortable at the beginning, but if they can breathe with the machine, they will feel better after a while. Have the patient hold the mask and make the patient feel that they have control and that they can remove it anytime they don't feel uncomfortable. However, you need to keep reminding them that this is for their own benefit. This is, to prevent intubation and so on. Most of the time, most of the patients, they will really love this type of treatment and they will actually ask for it if you remove it, if they are still in distress. And always, you can put 2 fingers between the strap and the patient's face to make sure that it is not very tight. For the CPAP, you use a CPAP level. You start at a level of 5 centimeters of water. You can start at higher level of 8. You can increase it up to 20 centimeters of water to achieve improvement in the shortness of breath and reduction in the respiratory rate, but also to improve their oxygenation. Of course, you will apply oxygen with the treatment. Your aim is to keep the saturation above 90 or 92%. For the NIV, you start with low pressure in the ST mode, meaning spontaneous and timed mode. This is more safe for the patients. Spontaneous means that the patient will initiate the breath. However, if they get tired or if they, for some reason, their breathing becomes slow, then the timed mode will go in, will start and or will take over and will start giving the patient tidal volume. So the inspiratory positive airway pressure, or the IPAP, you start at 8 to 12 centimeters, and then the EPAP, or the another word for it is PEEP, or the expiratory positive airway pressure, 3 to 5 centimeters of water. Then you gradually increase the IPAP to achieve the alleviation of shortness of breath, decrease the rate of respiration, increase tidal volume, especially if you have a monitor for that, and good patient ventilator synchrony. So again, NIV is not something that you start and you leave the patient. You need to start the NIV and interact with the patient and see what is comfortable for the patient and what is the number of the setting that would be more appropriate for the patient to achieve your goal. You want to eliminate CO2, you want to improve the oxygenation, you want to decrease the work of breathing. So you have to stay with the patient for a while, make sure that they are comfortable with the treatment. They will not remove the mask the minute you leave the room, and that you are achieving what you want. And always, you supply the oxygen and you increase the oxygen depending on the patient's needs. So initial monitoring, you check for air leaks. You can readjust the straps. Maybe the mask is not fitting well. Maybe you need another mask. Use humidifier, because that will make it easier for the patient when they inhale the air. Consider mild sedation. Some patients, especially if they have claustrophobia, you can give them IV lorazepam, small dose, that will calm them down. It will not affect their respirations significantly and will help in keeping the mask on. However, if you need to give frequently this kind of sedation, maybe they need invasive ventilation. Encourage the patient, reassure the patient, frequent checks on the patient, and do adjustments as needed. Maybe the patient had to remove the mask, maybe to clear his secretions. Then you have to apply it again. Then you need to fix it again and make sure that it is fixed well. Monitor blood gases. You have a baseline blood gas, and then within 1 to 2 hours, that will give you an idea if the patient is really responding, especially if they have CO2 retention. You want to see that there is improvement in the CO2 level so that you can continue with the treatment. Otherwise, if you're not achieving that goal, don't wait. Just go ahead and intubate the patient. Now, frequent blood gases can be a problem. In this case, you might want to put an arterial line. It depends on how frequent you want to do the blood gases. So things to monitor at the baseline, you look at the patient, you look at their respiratory rate, their pulse oximetry, level of shortness of breath and breathlessness, and you do a blood gas as an initial or baseline. That will give you an idea about his CO2 and level of PO2. Then you look at the heart rate, blood pressure, the ECG monitor, if you have it, a level of consciousness. If the patient is very sedated, then NIV is not the appropriate treatment, and the pain score. Then as you go on with the treatment, if the patient is keeping the mask on and you see that they are having good synchrony with the machine, they are feeling more comfortable, after 1 hour, you repeat the blood gas. And then after every adjustment you do on the setting of the ventilator, you do also another blood gas. Then the frequent, initially you do every 15 minutes vital signs in the first hour, then every 30 minutes for the next 3 hours. After that, if the patient seems to be stable enough, you can do them hourly. And they always include the vital signs, level of consciousness, and patient comfort. You also look at the skin, especially if several hours have passed without removing the mask. Clear so far?
Yeah, but I want to ask you, please, Doctor.
So,
In the beginning of starting CPAP, you set inspiratory and expiratory airway pressure, and you can start with 8 to 10, I think, or to 12.
yeah,
With IPAP, yeah, and you can max it to 20 centimeter. What about
right.
in the expiratory 5 centimeter? You can also increase it or stay with the setting.
No, you can. However, you look at what you want to achieve. You know, if the patient is having CO2 retention, the higher the difference between the IPAP and the EPAP, the better the ventilation and the better the CO2 removal. If you feel that, you know, CO2 is not a problem and the main problem is oxygenation, then you can make it just as CPAP and just use one level of pressure. However, using BiPAP might be more comfortable for the patient. So you can still keep it as BiPAP or bi-level, but increase the EPAP to improve the oxygenation. And if you need to, at the same time, remove more CO2, then you also increase the IPAP.
Right, sure. Thank you.
Clear?
Yeah, clear, Doctor.
Okay. So adverse events, generally NIV is safe. However, sometimes barotrauma can happen. They might have pneumothorax, but it's not as common as in the invasive ventilation. Hemodynamic instability can also happen, especially at the initiation of the treatment. Mild gastric distension might happen. However, it shouldn't be too severe to stop the treatment. However, the other disadvantage is that it needs frequent monitoring. So it needs someone to stay with the patient, especially at the beginning, at least for the first 15 minutes. And then you need to come and check on the patient very frequently. So if you don't have enough personnel, enough nurses, or enough even physicians to check on the patient, that might be a problem. Air leak, if you have this problem, then you make sure that the mask size is correct, that it has been fitted correctly. Use a mask, you know, you can change the type of mask, maybe tighten the straps if needed. And sometimes if you reduce the pressure, that also might improve the air leak that might happen. Skin irritation or abrasions, especially on the nasal bridge, then you can loosen the straps. Maybe there might be some air leak with that, but if the air leak is not significant, that shouldn't be a problem. Use a different size or different type of mask. In this case, you can use a full face mask to avoid having pressure over the nasal bridge, or use cushioning. You know, maybe apply some cushion over the nasal bridge, over the forehead, the points of contact between the mask and the face. Claustrophobia, you know, try to engage the patient with something else. You know, you have a patient who has something on his face and he's feeling claustrophobic, he wants to remove it. So try to distract him. And maybe if you have, you know, a TV monitor, maybe you can have him look at his iPhone, I mean, whatever phone. I'm not, you know, iPhone, smartphone, whatever. Maybe someone who can keep talking to him, distract him from this treatment. Maybe use a different type of mask, like a nasal pillow or nasal mask, so that they will not feel that there's something blocking their face. And maybe some light sedation, as we talked about. If they have nasal congestion, sinus pain, or E pain, It might help to use a nasal decongestant like a spray, and that would help to open the nasal passage and it would be easier to deliver the air. Humidify the air, that is very essential. And also you can reduce less pressure if needed, if possible. Dryness of the mucosa, always humidify the air. This is pressurized air, maybe at high flow. It will dry the mucosa, so you need to humidify the air. If a nasal mask is being used, again, this is this chin strap. You can apply it to keep the mouth closed, and that will help to, because if they are mouth breathers, they will have dry mucosa. Mucus plugging, if the patient is having lots of thick secretions and they have mucus plugging, again, humidifying the air that you give to the patient, give the patient some breaks from the ventilation, perform maneuvers like chest percussion and chest physiotherapy to clear the airways. And again, reducing the pressure might help because that will make it easier for the patient to cough up the secretions. Barotrauma or pneumothorax, you can still use the NIV. You can, however, reduce the pressures that you are using. Of course, if needed, you insert a chest tube to relieve the the pneumothorax. Weaning from this, any questions so far?
Doctor, please, I want to ask you about the time we can use the CPAP mask, face mask, or nasal mask. It will be how many hours, and the break, how many minutes or hours, if you can please
right. So again, it really depends on the patient. How, if you see that the patient is responding and they are less short of breath, they don't need the very high FiO2 or very high oxygen supply, maybe you can relieve them for maybe like even few minutes, sometimes even 15 minutes, maybe you can extend it to half an hour. Then you keep watching them because you need to see that their saturation is not dropping, that they are not becoming severely short of breath. Of course, when you remove the CPAP, you will remove the mask, you need to give them oxygen. You need to give them a different, maybe like just a simple face mask or even non-rebreather mask or maybe nasal cannula. I know that you are very short on high flow nasal cannula. That would be an option if you have it. But yes, you can give them breaks, especially if they are getting tired, like from having the mask on their face, if you want to relieve the pressure from their skin. So it can be done. However, initially, you can leave it on for hours. It depends on what you want to achieve. If you really want to avoid intubation, you can probably leave it for maybe 4 or 5, even more hours before you give him some relief. We had, few patients, but these are like special cases where you can keep it on for even days, but eventually they will have skin necrosis. And, again, you weigh your options here. If the patient, for example, is DNR and palliative care, you can probably keep it on for a longer period of time and so on. So again, you have to reassess your patient and see if they can tolerate taking the mask off and for how long. And that will give you an idea, how long you can keep it off. But yes, you can do it if the patient wants to.
Thank you.
So, yes, any other question?
No, thank you.
Yeah. So to wean the patient, you look at these guidelines. If they are clinically stable, the cause of the respiratory failure has improved. Respirations are less than 24 times a minute, heart rate less than 110, pH less than 7.35, pulse oximetry more than 90%, and FiO2 is less than 50%. Again, these are relative numbers, not absolute numbers. And again, you look at your patient, see how comfortable they are, and then you can either slowly titrate the IPAP downward by 2 to 3 centimeters each time, and after each time you just watch the patient, watch their vitals, make sure that they are still comfortable, they are not getting short of breath or tachypnic again, or you can just remove it and give them oxygen supply according to what they need, and again watch their breathlessness, or if they go into failure again or not. So if the patient demonstrates clinical evidence of distress, if yes, then you go back to non-invasive ventilation. If no, you discontinue and give them oxygen as needed. However, if from the start, they are still showing signs of respiratory failure and increased work of breathing, then you continue with the non-invasive ventilation. However, if they take too much time to improve, then you might consider intubation. Again, you need to see some improvement within 1 to 2 hours. If you don't, go for intubation, because if you delay intubation, the mortality rate would be higher. Any questions? So in conclusion, a trial of NIV is worthwhile for many patients. We have 2 really well-identified reasons, which are COPD with COPD exacerbation with CO2 retention and acute pulmonary edema. These 2 indications are very clear. Other indications, you can try it. However, they need good monitoring to make sure that they are responding or not. And make sure that you don't have contraindication for NIV. Usually we start with bi-level positive airway pressure ventilation in COPD, and you can use CPAP for cardiogenic pulmonary edema. However, BiPAP is not wrong to use it for pulmonary edema. For patients with hypoxemic respiratory failure due to causes other than cardiogenic pulmonary edema, an early trial of NIV is reasonable again, but you need appropriate and close monitoring. These are some references that I found very useful, because not because of the reference itself, but also because of the many references you will find within the articles. This is another one. And remember, it's easier to wear a mask than a ventilator. Please encourage each other and your patients and your family to put a mask on. Thank you.
Thank you very much, Dr. Hani. Thank you for sparing such valuable time. Thank you for the audience who interact with us, Dr. Muhammad Safi and Dr. Tahir. Dr. Hani?
Yes.
Do you have any last words for them?
Again, I mean, NIV is a good way of treating your patient if you know how to use it. So get familiar with it, because it can save a life. It can also save you from intubating the patient if you can, save him with NIV. That's the best advice I can give.
Thank you very much. Thank you once again.
Thank you. Thank you.
Barakallah feek, jazakallah khairan.
Barakallahu feekum.
Now we'll move for the second lecture or second part of this today with Dr. Nader Kharma. It is very important to initiate safe mechanical ventilation. It's important to ventilate the patient well during his ICU course. And it's really, really important to know how to liberate him from the ventilator. Safe liberation at good time will help the patient to improve and go to the medical ward or to the other place rather than the ICU. So Dr. Nader Kharma is a pulmonology critical care senior consultant He's one of the leading in this field, liberation from mechanical ventilation. He's leading one unit in HMC. He's holding a board degree from the United States. He participated with us many times, and he is awake since 7 a.m. till 3 a.m. in his duty, and then he came here for this participation. Thank you, Dr. Nader. Always you are helpful, and all the greeting for you. Go ahead, Dr. Nader.
Assalamu alaikum. مساء الخير للجميع. Thank you very much, Dr. Muhammad Qandil, for inviting me again to participate in this great activity for our brothers and sisters in Gaza, and that's the least we can do to help them in any way. I'm trying to share my, I need your permission to share the PowerPoint.
Yeah, sorry.
I think you disabled the sharing.
Yes, yes. Go ahead, Dr. Nader.
Okay, now I will. So let's maximize. Can you see the main screen, the full screen?
Yes, yes.
Good. Okay, so I really enjoyed the non-invasive ventilation lecture by Dr. Hani. Always a pleasure to hear that, and I'm sure it will be very helpful for your ventilation efforts in Gaza, especially with the limited number of ventilators. But as Dr. Hani said, I mean, it can be difficult to non-invasively ventilate because you have to watch the patient very closely as they can deteriorate. So he touched on the topic of weaning at the end, specifically weaning from non-invasive ventilation, but this lecture is dedicated for weaning specifically in the sense of weaning someone from invasive mechanical ventilation, someone who is with an endotracheal tube. So we will talk about different strategies today. First, I have no conflict of interests. Today, we will focus on discussing the importance of the practice of sedation interruption because sedation and weaning are very attached to each other. Explore different ways of determining readiness to wean, look at different ways of performing a spontaneous breathing trial, clarify when extubation is appropriate, and approach the difficult to wean patient very briefly. I'm sure that you have some of your patients that are difficult to wean and they may end up with a tracheostomy after 2 to 3 weeks. But I'm not sure how often do you find yourself in this situation. And weaning can continue, of course, until after tracheostomy. So tracheostomy is not the end of the weaning. Actually, it could be a new chapter of weaning the patient in a different, slightly different way. It's helpful to think of this continuation of mechanical ventilation in 2 steps. The first one is to check the readiness to discontinue or separate from the ventilator. So before we attempt to wean the patient, we have to agree that the patient is ready objectively for weaning or separation attempt from the ventilator. And this process should be as objective as possible, using both clinical and physiologic criteria. Now, you will find that clinical criteria are more helpful than physiological criteria, as I'll show in the next few slides. And then after you establish that the patient is ready for weaning and ready for separating from the ventilator, then you start the process of weaning. And weaning, in Arabic, weaning is al-fitam, like a mother is weaning her child from breastfeeding. So it's either a gradual process of separating someone from mechanical ventilation by decreasing the support in a gradual fashion, like they are on full mechanical ventilation on assist control or CMV, and then you go to a spontaneous pressure support mode, and then you go on pressure support gradually as tolerated, and then you increase the episodes of spontaneous breathing per day, give them some break at night. Or it can be the immediate shift from full support to spontaneous breathing For example, the patient is on CMV, and then you come in the morning, he is more awake, you stop the sedation, they look really good, and you just put them on TPs or the minimal pressure support and extubate them in 30 minutes. This is also possible. So weaning doesn't have to mean several days. And the more acute the process and the shorter the period on mechanical ventilation, the faster the weaning process will be. And the more gradual way of decreasing support will be often seen in patients who are on mechanical ventilation for 2 to 3 weeks, and they have failed previous spontaneous breathing trials. They tend to need a more gradual approach of decreasing support. So the first part is, before we talk about readiness, we have to understand the importance of daily interruption of sedation. So we know that in the past, we used to over-sedate the patients. And then with time, we discovered that sedation protocols that are using sedatives based on specific degree of sedation required, whether you are using the RASS score, like a Richmond Agitation and Sedation scale, or you're using other scales in the ICU, you are titrating the sedatives to achieve a certain degree of sedation. And also there's the other scores for pain, like CPOT, for example, score, where you are titrating painkillers to a specific degree of pain control. These are more effective than just putting someone on sedation until they are totally in comatose state. And then we reached a point where we found that also daily interruption of sedation, along with a calculated approach of titrating sedation to a specific number, is more helpful. So every day in the morning, your approach should be, can I decrease the sedation to the point where my patient is awake and following simple commands? And you would continue to decrease sedation until you reach that point, or your patient is not comfortable or agitated. There is nothing wrong with ventilating someone on no sedation. Some patients, especially older people with weak gag reflex, they may look very good and comfortable with an ET tube and not on any sedation, or very minimal intermittent sedation. And that's fine. It doesn't have to be that the patient is totally anesthetized or comatose when they are ventilated. Of course, if they are uncomfortable or agitated, they are fighting the ventilator, they're dysynchronous with the ventilator, they are harmful to themselves, they may pull the tube out or stand off the bed. Then, and the non-pharmacologic ways, like you speak with them, you try to reassure them, you try to explain the process to them. If all this is not working, then you have to use medications. So your goal is to assess the patient's neurologic status when you give them a sedation break. Make sure, because sometimes your patient may have developed a stroke. You don't know neurologically how they were looking when they first came to you. They were intubated very quickly in the emergency room, for example. So stopping sedation is a good way to check them. Make sure there's no neurological deficit. They are awake. Assess the need for continued sedation. And when you stop the sedation, you can use this as an opportunity to assess their readiness for weaning. So for after you stop the sedation, now how do you assess the readiness for weaning? You should first identify the patient who is ready to wean. And you have to understand that clinicians historically have been tending to underestimate their patient's ability to breathe independently. So let me give you an example. We know that some patients extubate themselves. When they're awake, they just pull the tube out. So you might be surprised to know that the rate of success after self-extubation is 50%. So 50% of patients will do just fine after they self-extubate themselves. So you were keeping them intubated and ventilated when in reality, they could have been extubated. So we as clinicians underestimate our patients' ability to breathe independently. And the other important thing is to identify patients who are not ready for weaning. So on the other hand, not all patients will do well, right? You remember the example of self-extubation, 50% of them will need reintubation. So you want to identify signals that will tell you that this patient should is not ready for weaning, and they need longer time to be ready. So this might be one of the most important slides, I think, in this lecture, is what are the criteria that you're looking for to say that this patient is ready for weaning. So number one, the cause of the respiratory failure has improved. So let's say that your patient has COVID pneumonia or bacterial pneumonia or COPD exacerbation. Do you think that the process has improved? Are you making progress? We know, for example, that most pneumonias need 3 to 4 days to improve on mechanical ventilation. Whereas if someone comes with pulmonary edema, they may improve in just 12 hours to 24 hours. So yes, it makes sense to extubate someone after 12 hours or 24 hours if the disease process is known to improve in that short time, like pulmonary edema. If you diurese them after load reduction, preload reduction, control the blood pressure, you may extubate in 12 hours, but it doesn't make sense to wean someone after 1 day of treating them with, they have streptococcal pneumonia, for example, or they have a hospital-acquired pneumonia. They will not improve in 1 day. They need some time. So that you should keep the primary disease process in mind, and did it improve or not? And then there are oxygenation parameters. The PF ratio should be preferably more than 150. Now, can you push it down to 120? Yes, maybe, but the patient will need more oxygen supplementation after extubation if you do that. They should have saturation at 90% or more with FiO2 of 40% or less, and their PEEP should be preferably 5 or less. Now, you can push it to PEEP of 8 in some cases. If they are very obese patients, COPDers, yes, maybe you can accept PEEP of 8, or I have extubated people with PEEP of 10, and I know some colleagues who have extubated very obese people with PEEP of 12. So these are exceptions, but the rule, I mean, the usual is you need a PEEP less than 8 or less than 5, most preferably. But that depends on your experience and what you're comfortable with. pH should be more than 7.25. The patient should be hemodynamically stable. Doesn't mean that they are off vasopressors. If they are on a small dose, a little bit of dopamine, a little bit of noradrenaline, then actually after you stop sedation, their blood pressure may even improve, and then they are ready for extubation. They should be able to initiate an inspiratory effort. So it goes without saying, if your patient is paralyzed with medications, then of course they are not ready for weaning. If the patient, you put them on a spontaneous mode or like pressure support, and they are apneic, they are just not breathing, then they could be too weak to breathe, or they could be very encephalopathic because of a medication, like the sedation hasn't gone. They have septic encephalopathy, they have a stroke or some central nervous system problem. And one of the common reasons why the patient will not breathe if you put them on a spontaneous breathing is that they are alkalemic, like they have respiratory alkalosis. So if you are over ventilating them on a controlled mode and then you put them on pressure support, they will not breathe because there's no reason for them to breathe with a pH of 7.5 or 7.6, for example. So far, I'm talking about simple criteria: hemodynamic stability, ventilation stability, oxygenation stability, and the ability to initiate a breath, and the disease process is improving. If you achieve all that, then that's a very good start to say that my patient is ready for weaning. Now, if you have additional criteria, that would be a bonus. If you correct their anemia, excuse me. So if you correct their hemoglobin, that would be a plus, because remember, hemoglobin carries the oxygen. So you improve your oxygen delivery, but there is no reason to transfuse someone unless their hemoglobin is less than 7. This is also based on several trials in ICU. So if your hemoglobin is 10 or 9, save the red blood cells. Don't waste them on the patient. He will not benefit from them. Keep them for someone else. So the golden number in ICU is 7 for transfusion. Temperature, of course, avoid fever. Remember that when you have fever, you produce a lot of carbon dioxide. So the patient has to ventilate harder. And if you are weaning, it's not the time to wean someone who is febrile, because that's extra CO2 production and effort for them. Mental status, preferably if they are awake and alert and responding to you, responding by simple things like raise your right arm, raise your leg, blink your eyes twice, lift your head off the pillow. If they do this, that would be great. And some patients will start writing with their hand on a paper if you give them. But you know, it's not a must. If your GCS, if the patient is even following commands inconsistently, just opening their eyes, that could be enough. So if all of this criteria is objective, right? None of them says the physician thinks that the patient is ready to extubate. None of them says that, or depends on the feeling of the consultant. It's all objective criteria. But still, you should understand that no randomized clinical trial has been performed to validate that. This is all consensus based on clinicians' expertise, and they are not very sensitive. Some 30% of patients who will not satisfy the criteria will still be successfully weaned. So that again stresses what I told you, that we underestimate the patient's ability to extubate. Even if they don't satisfy the criteria, they may still extubate. So what I told you is the most important predictors for the patient's readiness to wean. Before I go to other parameters, does anyone have any question? We are a small group. I see we have 13 people or 12 people. If anyone has any question, please interrupt me anytime. Okay. So I'll continue with that. So the measurements of oxygenation and gas exchange, I talked about the PF ratio, which is PaO2 that you get from the arterial blood gas, and FiO2 is how much oxygen you give the patient on the ventilator. So preferably you want this to be more than 150. There is the alveolar arterial oxygen gradient, or AA gradient. And to calculate that, you have to use a specific formula and to subtract basically the PaCO2 and the respiratory quotient from that to estimate the alveolar oxygen. So if there is an AA gradient, it suggests that there is shunting or VQ mismatch. If there is no AA gradient, then the reason for hypoxemia is often hypoventilation. So that is not terribly helpful for you in weaning. It's more a physiologic approach to hypoxemia. And then there are dead space. If you estimate your dead space, you will need an end-tidal CO2 monitor, which may or may not be available in your hospital. But if the patient has a very high dead space, it could be the primary disease process like ARDS, or that they have pulmonary embolism, creating lots of dead space. So these are just to help you assess why you are having oxygenation or ventilation issues. Now, what other weaning predictors, other than the objective criteria? I'm not going to read all of this, but there have been many attempts to prove the utility of different physiologic parameters in predicting the weanability of a patient. So some people looked at negative inspiratory force, how strong the patient is in breathing in, and measuring it in centimeters of water, maximum inspiratory pressures, respiratory resistance, vital capacity, respiratory frequency. And none of that has been found to be very sensitive or specific for weanability. So I am not advising you to do that. We have more complex indices that you are seeing here, with the exception of the rapid shallow breathing index. These indices are very complex to calculate and not very useful in predictions of weanability. And some ventilators can do what we call the occlusion pressure, or P.1. They measure the occlusion pressure, and that can help you in predicting weanability of the patient. Again, all these parameters can be complex, not available for everyone, and not very helpful clinically. So what is the approach for readiness for testing? If the patient is ventilated for more than 24 hours, then start using a daily ventilation protocol, liberation protocol. And to do that, I am repeating myself. The cause of the respiratory failure should be improving. The oxygenation, the ventilation, the pH, and the hemodynamics should be controlled. And then after you verify that the patient is ready from that perspective, do a rapid shallow breathing index. So from all the numbers I showed you here, you see all these NIF, MIP, static, dynamic compliance, resistance, CROP, core, integrative indices, all these numbers. The only one that you should look at, is worth looking at, is rapid shallow breathing index. It's well studied, easy to measure, and no alternative weaning predictor was shown to be superior to rapid shallow breathing index, which is very simple. What is rapid shallow breathing index? It's the quotient, or by dividing respiratory rate over the tidal volume. So let's say that your patient is now on minimal support or TPs, and you measure for 1 minute the respiratory rate, and you found that the respiratory rate is 30, and their tidal volume or expired volume is 100 mil. So you divide 30 by 0.1 liter. 100 mil is 0.1 liter. So 30 over 0.1, the quotient is 300. So if the rapid shallow breathing is more than 105, like 300 in this case, then the weaning failure is predicted. Whereas, let's say you put someone on a T-piece and their respiratory rate is only 10, and their tidal volume is 500. So 10 over 0.5 liter is 20. 20 is a very good number. It's less than 105. So this predicts that weaning will be successful in this patient. So to make your life simple, the cutoff point that we are using is 104. Use 100, just say 100. If less than 100, that's good for weaning. If more than 100, weaning failure is more likely. Remember, I'm talking likely and unlikely. So it's not 100%. You may have someone with a rapid shallow breathing index of 110, and they will still pass the trial. And you may have someone with an index of 50, and they will still fail. But most of those, the lower the number, the better also. The lower the number, like less than 100, less than 50, is even better. So how do you do the procedure? You allow the patient at least 3 minutes to stabilize their spontaneous breathing pattern. The ventilator frequency must be off, like they should be on a T-piece with minimal or no pressure support, and then measure the expired volume and respiratory frequency for 1 minute. The original method was putting a spirometer, disconnecting the ventilator and putting a spirometer at the ET tube. But because that may not be available, you can keep the same circuit, but just put the pressure support to 0 and let the patient breathe on their own. And after you count the frequency and the tidal volume for 1 minute, then divide frequency by tidal volume in liters and get your number. And that's basically what I said. If it's greater than 100, correlates with weaning failure, less than 100, weaning success. So after you have established your objective criteria, and after you have done the rapid shallow breathing index, then what is the best method of weaning? So may I ask anyone in the audience, what would you do at this stage in your ICU? Which mode of weaning, ventilation weaning you would do?
Support SIMV mode.
Sorry, doctor, you're saying SIMV or
the TPs also we can get.
TPs? You can use TPs, okay. What else?
Yeah, SIMV mode and pressure support.
Okay, so like different.
And we have TPs also, that's all.
Okay, so yeah, TP is pressure support, SMV. Do you have like a tendency to use one over the other in a special situation, or it depends on like what's available?
No, what's available, yeah.
Okay. So here, I mean, and I'll tell you what we do. So, I mean, as I said, we can wean after that point by switching someone to spontaneous breathing mode on pressure support and progressively decreasing the level of pressure support. So we start, for example, at 15 and then go down to 12 after a few hours, and then go down to 10 in a few hours. I mean, you can do it gradually. But sometimes we have automated modes. Like, for example, I heard that you're getting Hamilton ventilators. Someone, I think Dr. Muhammad Qandil told me that you might be getting Hamilton ventilators later on. And they used an automated mode called ASV. And ASV works by decreasing pressure support gradually on its own without your intervention. And then when the patient is ready for extubation, it will tell you that. So you might be getting that soon, and it can be helpful if you are short-staffed, because the ventilator will decrease pressure support on its own. So if the patient is breathing through the ET tube, you can use the T-piece, as you said, and that's without any ventilator support. So you can just connect the patient to a T-piece circuit. Or sometimes some clinicians will just decrease pressure support to 0 and PEEP to 0. They call it ZEEP. And sometimes we keep some PEEP of 5, for example, and we stop the pressure support. There are many variations. And the other way of doing it is to keep them on pressure support mode using low level of pressure support. So for example, you say, I'll just use 5 of pressure support or 6 of pressure support. And sometimes if the tube is small, like if a woman has a tube of 6.5 or 7, and there's lots of mucus inside clogging it, the resistance could be high. So even a pressure support of 5 may not be enough. So some ventilators have mode called automatic tube compensation, or ATC. So the ventilator will give the least amount of pressure support to overcome the airway resistance. So that's another way. So there's ATC, automatic tube compensation, low level of pressure support, like 5 or 6 of pressure support, T-piece, and you also mentioned the SIMV. So several studies compared T-piece to automated tube compensation or pressure support, and there was no significant difference in rates of weaning, in reintubation or pneumonia. So if you use T-piece or pressure support, you're okay. If you look at the latest meta-analysis, like putting all studies together and reaching a conclusion, probably pressure support is slightly more successful, very slightly more successful than T-piece, and it could be easier on the patient. Now, what we know is that the least effective way is SIMV, and that's from several studies showed that SIMV is the slowest way to wean someone, and the fastest ways are T-piece or pressure support. And maybe pressure support is the fastest. And SIMV, we know, is the slowest way. So I think that there's no really strong reason to use SIMV, but I mean, you can use it if you have to. So what we do is, for a spontaneous breathing trial, we use pressure support with pressure of 10 or less and PEEP of 5 for 30 minutes to 2 hours. And then we do a blood gas, ABG, to check the vital signs. As I said, make sure the rapid shallow breathing index less than 100. And if the patient passes the spontaneous breathing trial for like half an hour to 2 hours, make sure they have a good gag reflex, cough reflex with minimal secretion. So you can ask the nurse, for example, how often do you need to suction him? If the nurse tells me, oh, I'm suctioning every 1 hour or 2 hours, this is too much secretions. Ideally, you want it to be less frequent than 3 hours or 4 hours. So if she says I'm suctioning every 4 hours or less frequent, this is good. If it's more frequent than every 3 to 4 hours, that's too much secretions. And maybe even if the patient passes a spontaneous breathing trial, maybe it's better to keep him on for another day, just to make sure that the secretions are less. So maybe he needs more time for the antibiotic to start working, to decrease the secretions. Maybe he needs better physiotherapy of the chest. He needs better airway clearance or stronger cough. So liberation from the ventilator is one thing, and extubation is something else. The patient could be liberated, like he matches all the readiness criteria, and he does well on a spontaneous breathing trial, but his cough is very weak, or he has lots of secretions. If you extubate him, you know that there's a high risk of mucus plugging and needing re-intubation within the next 48 hours. Last but not least, other than the cough strength and the secretions, the level of wakefulness. If the patient is very drowsy, very sleepy, typically GCS less than 8, you should be careful because there's also higher chance of re-intubation in these patients. So what is the criteria for failed weaning? So if you put someone on a spontaneous breathing trial with pressure support or TPs, you look for clinically, you look at the patient, are they using accessory muscles? Do you look at their sternocleidomastoid, their scalene muscles? Are they having a thoraco-abdominal paradox? Like they are having what we call abdominal breathing. Are they diaphoretic? Look at the sweating. If they are starting to sweat, tachypnic, hypertensive. If they are hypotensive, it's actually a worse sign. It means it's like a stress test for their heart. If they're hypotensive, it could be cardiac ischemia. So look at the patient, their vital signs, their heart rate, their respiratory rate, and see how they tolerate that. If they do not tolerate that, then you know that there's no even point of doing a blood gas. You should stop the spontaneous breathing trial. Don't even wait for a blood gas. Now, if they are comfortable, their vital signs are stable, then you can say, okay, after 30 minutes or 1 hour, I'll do a blood gas. And if the blood gas looks good, then, and actually, to be frank with you, I don't even think you need a blood gas. If the patient looks comfortable and they're vitally stable on TPs or pressure support for half an hour to 1 hour, and their oxygenation is good on minimal FiO2, unless you know they have a history of CO2 retention, like COPDers or otherwise, you don't really need to do a blood gas, especially in your situation with limited resources. You don't have to do a blood gas on every patient. So other things that can tell you, of course, that someone is not doing well on a spontaneous breathing trial is if they are desaturating. This is a very quick sign of failure. If you put them on a TPs and their oxygen starts dropping below 90%, then you know that they have a very limited cardiopulmonary reserve. And you have to think, is it their heart or is it their lung? Are they desaturating because they still need oxygen and support because the pneumonia is bad, the COPD exacerbation is not resolving, the ARDS is still, their lungs are too stiff and they have hard time overcoming that, or because they have cardiac ischemia. So I find that doing an ECG is helpful in these patients, or just looking at the monitor for any signs of ischemia. They may need more diuresis, some furosemide or Lasix, or some blood pressure medication to decrease the ischemia. Of course, somnolence, agitation on a weaning trial can be a sign of failure. If they are somnolent, think that their CO2 is rising. They are hypercapnic, maybe. If they are agitated, it could reflect hypoxemia. Sometimes if the patient is hypoxemic, they get agitated, and you should be able to see that easily on pulse oximetry. They could also be agitated because they're not hypoxemic, but because of air hunger, or because they are scared, because they can't breathe comfortably. So this is the point where you have to use your clinical judgment to see if the weaning trial, the spontaneous breathing trial, should continue or should be aborted. If the patient matches all the weaning readiness criteria, the stability, hemodynamically, oxygenation-wise, the rapid shallow breathing index is good, and they pass a spontaneous breathing trial for 1 hour or so, as I said, check their cough, their level of consciousness, and the volume of secretions. If all that is good, you can proceed with extubation. The airway patency or a cough leak test is not a must. You don't have to do it on everyone. But if your patient has been intubated and ventilated for more than 5 days or 1 week, it was a difficult traumatic intubation, like someone tells you the tube was not going in easily, or it's a female with a big endotracheal tube, like size 8 or bigger. These are risk factors for post-extubation stridor. So they may have edema, laryngeal edema, and it might be helpful to do a cuff leak test. So you deflate the cuff and make sure that there is an audible leak, or you can see a significant leak on the ventilator. If there's no leak, it could be a false positive test, but it might be prudent if you think that there is edema and chance of stridor after extubation to give them steroids. And typically we give methylprednisolone 40 milligrams 4 hours before extubation. You can just give 40 milligrams methylprednisolone or any equivalent dose of steroids and extubate after 4 hours. So what if the patient fails? Like, let's say that you did a spontaneous breathing trial and they are failing. They are sweating, they're tachycardic, they're tachypneic, they're dropping their saturation. Then what should you do? First, you have to think in physiologic principles. The reason for weaning failure is largely attributed to 4 problems. Number 1 is a CNS problem. The patient is not awake enough or on excessive medications that decrease their level of consciousness. Number 2, there's a problem with the heart. It could be weaning-induced cardiac ischemia. Whenever you are putting them on a spontaneous trial, it's like a stress test. So you may expose ischemia in the heart. Number 3, the patient has a lung problem that hasn't corrected or improved yet. Their COPD or asthma hasn't improved, their pneumonia hasn't, they have a pneumothorax, they have a big pleural effusion, they have an empyema that needs to be drained, something like this. And number 4 is a generalized weakness. Like the patient has been ventilated for a long time and they are just very weak, including diaphragmatic dysfunction. And that's why they are not tolerating a weaning trial. So broadly, these are the 4 reasons. Think the brain, the lung, the heart, and generalized muscle weakness, including the diaphragm. So the number 1 reason, other than the 4 systems, is there's an imbalance between work of breathing and respiratory muscle capacity. Now, what does that mean? It means that the muscle, the respiratory muscle, has to work hard because there is excessive load on it. And if you remember the ventilation lecture, the power needed to breathe has to overcome your respiratory system compliance and resistance. So if the patient is still having bad asthma exacerbation or COPD, then the airway resistance is just too high for them to breathe. Could be also a problem with the ET tube. The ET tube is kinked or blocked with excessive secretions. It's very old and it has been there for a long time. And a number 7 tube may become a number 6 tube after 1 week or 2 weeks if it's getting blocked with lots of secretions. Number 2, it could be a compliance issue that makes it harder for them to breathe, like they have pulmonary edema. Maybe you have to give them diuresis. They have chest wall edema. Or if you push in their chest and their abdomen, it's very edematous, lots of fluid. Look at the fluid balance. Give them Lasix, furosemide, shrink them a little bit. Maybe the patient has stiff lungs. After COVID, we see lots of lung fibrosis. It needs time. It may improve and it may not improve. And there's no specific therapy for that. But pneumonia, for example, will need time to improve, and it will improve with antibiotics most of the time. So these are just few examples of imbalance between work of breathing and respiratory muscle capacity. The other big example, you may have a normal work of breathing, like normal load. So the lungs are normal, the chest wall is normal, the resistance, the compliance are okay, but the patient is just too weak to take a normal load. So here the problem is not in the load, the problem is in the muscles of the patient. They are too weak. And here you need rehabilitation to improve their strength. And I know that this is a very big problem. You know, COVID patients stay in the ICU for an average of 14 days of mechanical ventilation, and it can be a huge burden on the staff in the ICU. How do you do rehabilitation for all these patients? How do you make sure they sit up in the bed? How do you mobilize them? It's a big issue. Other issues, think about volume. These are simple things. If there's an extra volume, you can adjust how much fluid you give them. You can give them more Lasix to get rid of fluids. Cardiac dysfunction, I mentioned that. And I'm not saying that the patient needs a heart surgery or a cardiac catheterization. On the contrary, it could be giving them some diuresis, beta blockers, hydralazine, ACE inhibitors. Think about if someone's blood pressure is always in the 160s and 170s and they have a weak heart, that's too much pressure for the heart to work against. So if you decrease their blood pressure, it makes it easier for the heart to push forward. This is the afterload reduction that we talk about. Neuromuscular weakness, I mentioned that. Delirium, anxiety. So going back to the brain, it's not only the excessive medications, the sedation, it could be delirium, especially in old people. The medications we give, like benzodiazepine, benzodiazepines are very known to cause delirium in ICU, especially for elderly. So if you have propofol, it would be a cleaner agent to use. If you have shorter acting agents like fentanyl, it would be easier to not to cause delirium on the patient, or remifentanil. So what agents do you use for sedation these days?
Propofol and Dermicon. And thiopental also we can still use it in our ICUs.
Thiopental?
Yeah.
Wow, okay. But propofol is a good agent.
We didn't have dexmedetomidine, we didn't have clonidine. Just as I told you, propofol and midazolam and thiopental. Yes, that's all.
And do you use any opioids like morphine or fentanyl for pain?
No, we can use morphine also, fentanyl. Morphine and fentanyl only.
Okay, so if you can use, if you have the supplies, if you use fentanyl and propofol, it would be better. Midazolam, if you think that the patient will stay for like long time, they're very sick, you don't think they will wean before 3 days or 5 days, then you can use midazolam and fentanyl. And once they are closer to weaning, switch midazolam to propofol and keep fentanyl. But thiopental, I personally haven't used that in a very long time. And morphine is much worse than the fentanyl. It will accumulate in the system and it can cause more neurologic problems, especially in kidney failure patients. So if you have fentanyl, it would be better to use it than morphine. But it's good. I mean, you have few medications to work with. Yeah. And oral medications, and the shortage of COVID medications in the US, they have used lots of oral medications, like you mentioned clonidine. They have used, gabapentin, pregabalin. I think these are more expensive drugs. I don't know if you have them, but even they used oral medications like oral morphine and oral lorazepam in the shortage of IV medications. Do you use quetiapine or haloperidol or anything like this sometimes?
No, sometimes haloperidol we can use. Sometimes, yeah. In such delirium case, yeah, we can use.
Yeah. Okay.
But a little, not too much every day we can use. Okay.
Yeah, I agree with you. It's only for intermittent usage, not for main sedation. Yeah, I agree with you.
Yeah.
So other than that, the metabolic disturbances, pay attention. I mean, also, if you happen to check for electrolytes, make sure, like sodium, for example, if the sodium is more than 155, especially more than 160, it can affect the level of consciousness of the patient. So metabolic disturbances, metabolic acidosis, if it's uremia, if uremia is very severe, it can cause neurological disturbances and difficulty in weaning the patient as well. Hypophosphatemia, very important. Phosphate is used to make ATP, which is the energy currency in your body. If you don't have ATP, you don't have energy. And if you don't have phosphate, you cannot make ATP. So hypophosphatemia is one of the main causes also of weaning failure in patients. So very important to supplement with phosphate, whether IV or oral, like whatever form you have. Adrenal insufficiency, if you have signs of adrenal insufficiency like hyponatremia, hyperkalemia, glucose impairment, blood pressure on the low side, it's now most COVID patients are given dexamethasone or some kind of steroid, which is which is good, but adrenal insufficiency is also important to think about for weaning failure. I think I mentioned that in my previous slides. I said that on comparison, pressure support, ventilation, and TPs are the most successful ways of weaning. SIMV was found in many trials to be the longest, the worst way to wean someone is to use SIMV. It takes the longer time. So other than thinking why your patient is not successful with a spontaneous breathing trial, if they fail, the first thing to do is to rest the patient. So put them back on full mechanical ventilation support. Don't leave the patient who is failing a spontaneous trial, don't leave them on a low support system because they can arrest, at the end, it's a stress test. So put them back on CMV or assist control mode, or at least a high pressure support, like to compensate for their being tired and fatigued. Only do one trial per day. And because you are limited in staff and resources, this is actually good news for you, that if you don't have to repeat spontaneous breathing trial. Do it once per day. Don't do it twice or 3 times. It's not better than doing it once per day. Because if you continue to repeat a spontaneous trial many times per day, you will fatigue the patient. Again, think about it as exercise. If I ask you to go to the gym or to go running outside 3 times a day, that's not better than doing it once a day and resting and build your muscles. So you exercise the patient. If they fail, let them rest for the rest of the day, and then tomorrow in the morning, repeat the process again. So a non-invasive ventilation, just one slide on that. Dr. Hani spoke about it, but here I'm focusing on the role of non-invasive positive pressure ventilation for post-extubation. And the best studied category is COPD patients. Actually, now we are intubating less and less COPD patients and managing them with non-invasive ventilation. But even if they are intubated, it's easier to extubate them on BiPAP or non-invasive ventilation. Also, I would say if you have someone with heart failure or fluid overload, after discontinuation of mechanical ventilation, their preload will increase. And the best way to counteract that is, of course, to optimize their heart function by diuresing them and adding cardiac medications. But also, after extubation, you can put them on non-invasive ventilation that will bridge them in a nice way. And then you can wean non-invasive ventilation in another day or 2 after Dr. Hani told you. Don't wait for them to fail after extubation and then put non-invasive ventilation. So there is a difference. Some people say, extubate them and then I will see what happens. If they fail, I'll use an IV. This is wrong because the best way is to extubate and then put them on an IV right away. Of course, you take the tube, you suction them, you make sure that everything is clean and all this, and then you put the mask on them. I'm not saying just take it out and right away. No, give them time, of course, to clean their mouth, suction them well, suction their nose, take the NG out if you think they don't need the NG, or keep it. You can keep it and put the mask on top of their face. Can you do it NIV in other patients like non-COPD, non-heart failure? The answer is yes. It's not very strongly supported by evidence, but sometimes if the patient, in your opinion, is still a little bit weak, like the pneumonia has improved, the COVID has improved, the X-ray is improving, they are tolerating, but they are a little bit maybe tired, or you think they will fatigue, or they have a big neck, and maybe you think they have obesity hypoventilation, they may have some obstructive apnea at night, then you can use non-invasive ventilation as a bridge after extubation. But use your clinical judgment. And if they fail non-invasive ventilation after extubation, don't keep wasting your time with non-invasive ventilation. If they are failing on it, re-intubate them again. So again, as Dr. Hani said, mostly we use NIV after extubation in COPDers, in those who do not have difficult airway, in those who don't have excessive secretions, and in those who don't have impaired mental status. So If your patient has low GCS and they're just confused, you cannot put NIV. They will not protect their airway. If they have excessive secretions, like you do an X-ray and they collapse their lungs, then there's a mucus plug. You have probably to re-intubate them again. Or if they go into shock, septic shock or cardiogenic shock, shock and non-invasive ventilation are not the best combination together because when you have shock, you intubate the patient to relieve the diaphragm. The diaphragm can use up to 40% of your cardiac output in a septic patient because they are very short of breath. Lots of blood is going to the diaphragm. If you intubate them and relax the diaphragm, then that extra cardiac output can go to vital organs. So shock and non-invasive ventilation, also be careful of doing them together. With that, I end this brief lecture, but I think I'm just on time, and I'm happy to take any questions if you have them. Thank you.
Thank you very much, Dr. Nader. We have Dr. Muhammad. He has a question. I think he can unmute himself.
Can you hear me?
Yes,
Yes, Doctor.
Okay, thank you, Doctor, very much for your lecture. I want to ask about the weaning failure for arterial blood gases. We didn't you didn't discuss a lot about the arterial blood gases. Do we should follow it related to the case of the patient? And what if the PCO2 is still high? We are going with the weaning or stop and correct this increasing in the PCO2.
Okay, so if I understand your question right, you're asking, Yani, what is the role of ABG or whether it should be done, right?
Exactly.
So as I said, in most patients, like let's say that the main reason of intubation and ventilation is hypoxemic respiratory failure. And you know that from your daily blood gas, the CO2 is in the normal range. And you treat the pneumonia and the patient is improving. They're more awake. You do a spontaneous breathing trial. They are not sweating, not tachycardic, not tachypnic. Rapid shallow breathing index is less than 100. Vital signs are stable. Oxygenation is stable. After 1 hour, they have good cough. They have no secretions. You extubate them. You don't need to do a blood gas because think about it. If you think that their CO2 is rising during the spontaneous breathing trial, you should see that the oxygen saturation is decreasing because with you remember that hypoventilation is one of the causes of hypoxemia. So if it's a significant hypoventilation, you should see some drop in the saturation. Number two, you should see some change in the level of consciousness. Number three, you see accessory muscle usage or abdominal breathing. If you don't see any of that, then there is no reason to do a blood gas. Now, of course, we personally do a blood gas on almost all of these patients.
Exactly.
And I am telling you, I was never surprised, I don't remember, and maybe Dr. Hani can say, to see that, oh my God, the patient looks great, but the CO2 is 80. Because if I see this, then it means the blood gas is wrong, basically, and I would repeat it.
Exactly.
You know, so clinically, if it looks good, it's very unlikely that you will be surprised. However, if you know that your patient is a COPDer and he's a retainer, like you know that his normal CO2 is like 50 or 60, and he compensates by increasing the bicarbonate. So his PCO2 is high, but his bicarb is high. So his pH is more than 7.3. And if you do, maybe it's better than to do a blood gas just to make sure. And in this case, if the pH is still 7.3 or above, I would still extubate the patient. Now here comes your clinical judgment. Let's say that the pH is between 7.25 and 7.3. The CO2 went up by a few points, a few millimeters of mercury. Then that could be a reason for you to extubate to BiPAP, like to NIV, exactly what we said in our last slide. This is the right patient, the hypercapnic patient, to benefit from non-invasive ventilation post-extubation.
Okay, done. Thank you, Doctor, for your clarification.
Well, I hope you answered. I answered.
Clear, yeah. Thank you.
Please, Doctor, I have one question, please.
Sure, Doctor.
Once we have a patient referred from other hospital to us with ventilator-dependent case, more than 9 months stay in other hospital in mechanical ventilator. In such cases, do you have any idea how to make weaning trial or such case to wean the patient from mechanical ventilator? Do you have one case like this, and how can you do with this patient?
Yeah, I feel for it's frustrating to have someone who's ventilated for 9 months. I assume it's a tracheostomy patient then?
Yeah,
And
tracheostomy.
tracheostomy?
Yeah.
What's
and
his
still
primary
mechanical ventilator, SIMV mode.
Okay, what's his primary problem?
No cardiac problem. No cardiac problem. This COPD case, and this Foreman. I don't know how can the other hospital keep the patient on mechanical ventilator for this time, but it's 9 months in mechanical ventilator and comes to us. We have do some spontaneous breather trial, and we have do different modes to wean the patient, and we have also extubate the patient and let's say there for many days, but returns back again to the mechanical ventilator. So I think we have do 3 trials, successful trial. The last one, the patient arrested and died.
So, it's hard to give an answer because I want to know, like, what's the primary problem? He was intubated because of his COPD in the long time ago?
Yeah.
COPD exacerbation?
COPD like fibrosis, yeah.
But then after COPD, he also has fibrosis.
Yeah.
And he is tracheostomized on mechanical ventilator. And he came to you for weaning or with another acute problem?
No, with the same problem.
Your
continuity of care, I guess, like this.
Yeah, best continuity of care. Can just for you to continue taking care of him.
Yeah.
So, this patient with COPD, I mean, if he comes to me for weaning, long-term weaning, the first thing I will make sure that he doesn't have a cardiac dysfunction, because COPDers have lots of cardiac disease. And it's important to do at least an echocardiogram or ECG or basic physical examination to make sure that he has a reasonable cardiac function. He may have right heart failure, cor pulmonale, pulmonary hypertension. So it could be lots of things in addition to COPD that prevents weaning. The other important thing I think about for the COPD is I will try to wean him using pressure support in a gradually decreasing way, and then transition him from invasive ventilation to BiPAP if I can. And this has to be done in a very specialized way. And it's beyond the scope of the lecture, but basically you will have to look if he's tolerating pressure support at lower and lower levels. Then you try to do trach mask, which is like T-piece, and then rest him at night on pressure support, and then downsize his tracheostomy and use an IV while you are downsizing the trach, and then gradually transfer him to non-invasive ventilation. Now, your patient, I don't know much about him, but remember, a 9-month ventilation is a long-term ventilation. And these patients, do you know what's their mortality? Their yearly mortality is around 50%. يعني 50% من الناس long-term ventilation will die every year. So, I mean, this is a high mortality case. So I don't think you should feel surprised that after 3 attempts, he arrested and you couldn't resuscitate him. I'm not very surprised. These are difficult patients.
Thank you, Doctor.
You're welcome.
We'll give 30 seconds if anyone has a question. We have Dr. Saber Sarafandi. He is pulmonology consultant now in Gaza. He's the head of pulmonology department in Nasser Medical Complex. He attended the course with us from the first day to the last day. We appreciate his commitment. So we'd like to hear from him about feedback about, want to his participation. I mean, Dr. Saber, can you speak?
السلام عليكم.
وعليكم السلام.
وعليكم السلام دكتور صابر.
First of all الصراحة أنا أقدم بجزيل الشكر للدكتور نادر خرب على هذه المحاضرة الرائعة والشيقة. الويننج from mechanical ventilation صراحة we are facing يعني in daily challenge this problem مع all of our patients. وكان برضو في المحاضرات الأخرى كان برضو يعني اللي هو الميكانيكال فنتيليشن والاير واي مانجمنت. يعني كان صراحة يعني بنتشكر قسم العناية المركزة في مؤسسة حمد الطبية اللي كنت أنا أحد يعني طلابها في يوم من الأيام. على هذا يعني صراحة الانتنسيف والكونسايز كورس في يعني ميكانيكال فنتيليشن في الانتنسيف كير يونت ات اول. كانوا صراحة محاضرين يعني على رأسهم الدكتور إبراهيم فوزي، نتقدم له يعني بجزيل الشكر بداية في الانترودكشن تو ذا كريتيكال كير مانجمنت. كان برضو الدكتور أحمد لبيب برضو في الايرواي مانجمنت، وكان برضو الدكتور نادر خرمة كمان، وكان الدكتور نتقدم الشكر للدكتور هاني الجاعوني، الدكتور عادل كمان، برضو الدكتور اللي هو تسليم رضا وهو يعني ماي تيتشر في البلمونري وفي في الانتنسيف كير يونت في الكيس بيزد فنتيليشن مانجمنت انتراكتيف سيشن. it was very 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 interesting. الدكتور محسن برضو شاهين كان له يعني انبوت صراحه كان رائع جدا. داموا اللي اتحفنا بالكيس في الحالات اللي هو المانجمنت في الار دي اس سيتنج والبيب سيتنج والاوجمنتيشن و how to manage critically ill patient. صراحة تكون يعني a good impact in our doctors and our junior اللي هم يعني احنا كان learning process و learning information، تعلمنا حاجات جديدة من هذا السيشن، وحيكون له good impact على حتى الجونيور كمان. يعني السينيور والجونيور حيتعلموا من هذا الكورس، وجزاكم الله كل خير عنا كل جزاء، وهذا إن شاء الله يكون في ميزان حسناتكم. نحن صراحة نواجه فيروس شرس عنيد في وضع احنا صراحة يعني مقارنة بدولة قطر يعني we are working under very limited resources، لكن العزيمة ووجود الطواقم الطبية المصرة يعني والحمد لله يعني العلميا متقدمين جدا 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 سنخطي هذه المرحلة، وإن شاء الله تكون في ميزان حسناتكم، ونتقدم لكم بجزيل الشكر يعني إن شاء الله.
جزاكم الله خير.
جزاكم الله خير، الله يقويكم، وإن شاء الله ننصركم في هالمهمة الصعبة هاي ونكون معاكم، واحنا بنساعد بكل اللي بنقدر عليه ان شاء الله.
الله يحييك.
شكرا جزيلا دكتور صالح.
والله احنا على تواصل، احنا عندنا في الجروب يعني حتى في عندنا حالات في الكيس ديسكشن، في عندنا جروب موجود. الدكتور يعني الدكتور محمد قنديل صراحه يعني سوى جروب، وهو يعني له كل الشكر على الارينجمنت. الدكتور برضه احمد مفيد المخللاتي برضه كان يعني له دور. يعني حتى لو انه في كيس باي كيس ديسكشن في الديفيكالت ويننج، في الميكانيكال فنتيليشن، في الاي ار دي اس مانجمنت، في هاو تو يعني الانتراكتيف ميديكيشن. حتى اعتقد انه في يوم الاربعاء القادم في اونلاين برضه ليكشر على المانجمنت بالكوفيد من الاي دي تيم مع اسوشيشن مع البلمونري تيم في حمد، في المانجمنت، في الانتي فايرال تريتمنت، في الانتي انفلاماتوري تريتمنت، الكليكسان، البروتوكول. احنا حاليا في وزاره الصحه عندنا بروتوكول لمعالجه يعني الشق العلاجي من البارت، يعني هو الاكسجين هو نمبر 1، الاكسجين والبرونينج والاويك برونينج هذه في الاكسجين مانجمنت والميكانيكال فنتيليتور. لكن بيبقى الشق العلاجي من الانتي فايرال كومباينيشن انتي فايرال. زي ما حكيت انا احنا we have limited resources we are following يعني تقريبا حوالي يمكن 60 او 70% من البروتوكول اللي موجود في مؤسسه حمد في السي تي سي هوسبيتال من الادويه اللي موجوده. حتى هذه اللحظه there is no randomized control trial to confirm which drug is the best، لكن احنا بقدر الامكان بنحاول. لكن في اشياء موجوده في المانجمنت كالاكسجين، اويك برونينج، كليكسان، ديكساميثازون، هذول لهم يعني very 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 effective management خلصنا حديثا يعني مؤخرا من السي بلازما بروتوكول حنعمل فيه، يعني الكونفالسنت بلازما حيكون ان شاء الله قريبا سوف يقدم الى مرضانا اللي موجودين في العنايه المركزه في مستشفى غزه الاوروبي او المستشفى الوبائيات، وان شاء الله يعني يكون يعني جزء يعني من البارت اوف مانجمنت لهؤلاء المرضى ان شاء الله.
الله يقويكم.
حياك الله دكتور صابر. الكل دائما بيسأل عنك كان وبطمن عليك ونحكي لهم دكتور صابر.
والله انا مشتاق لكم واحييكم وربنا يشد على ايديكم يعني صراحه. طبعا يعني احنا نتباهى بنقول لهم دائما احنا الكريتيكال كير او المانجمنت اوف انتنسيف كير في قطر كانت الاقل مورتاليتي يعني في دول معينه ودول اوروبيه، فهذه يعني صراحه شيء بيرفع الراس وبارك الله فيكم يعني.
تسلم دكتور صابر. احنا بنقول لهم دكتور صابر هلقيت ليدنج في غزه وما شاء الله هو ماشي مع البروتوكولات ويز بالمونولوجيا السوداء.
والله ان شاء الله احنا بنحاول قدر الامكان.
ربنا
الله يحييك. الله
يجزاك حسناتك. الله خير دكتور صابر.
الله يسلمك. الله يسلمك يبارك فيك. شكرا جزيلا.
شكرا. في النهايه نشكر الدكتور نادر خرمه والدكتور هاني الجعوني على هذه المشاركه وبارك الله فيكم. شكرا جزيلا.
جزاكم الله خير.
السلام عليكم ورحمه الله.
السلام عليكم. صباح الخير.
وعليكم السلام.
مع السلامه. امان الله. مع السلامه.
يعطيكم العافيه.
الله يعافيك.
الله يعافيك.